This week on the BackTable podcast.
I think one of the points you touched on when you said something about local personalities, I think that geography plays a big part in it. I think of New Orleans as, I wouldn't say it's an underserved area, but I mean, not by any stretch. But I think there's less competition here than in some of the places like practicing interventional cardiologists and radiologists in places like the Northeast or California or some more major metropolitan areas. I think when there's less work to go around, then it more becomes a turf battle.
Yeah.
I think that we've done some podcasts in the past when we talked to people who are in extremely underserved areas, and they're like, turf battles don't exist. We're just dying to get someone who can help, right? It's all about finding someone who can help and has the patient's best interest at heart. And so, my advice is, or maybe not advice, but my observation is that, if you just always go in, think of the patient first and try and be friendly and collaborative, you'll find out what kind of environment you're in pretty quickly.
I think for our generation, you can tell by this podcast, it's there's a little bit less war going on and more kind of friendship and support. And I think that's certainly true for interventional radiology and interventional cardiology. That's been my experience.
Hello, everyone, and welcome to the BackTable podcast. BackTable is your resource to connect with your endovascular colleagues and learn tips, techniques, and the ins and outs of the devices in your cabinet. This is Aaron Fritz returning as host, and I'm very excited to introduce our guest today, Dr. Achal Sahai from Tulane, the Tulane Interventional Cardiology Department in New Orleans, and Dr. Chris Beck with Regional Radiology in New Orleans, Louisiana. Welcome, guys. Before we dive into our topic today, just want to say a quick word from our sponsor, RadPad. RadPad was developed by physicians for physicians, clinically proven radiation protection during cine and digital subtraction angiography. Don't bet your career or your health on anything less. Trust RadPad radiation protection shields for all your fluoro-guided interventions. See radpad.com for more information and contact info@radpad.com for a free radiation evaluation and a no-brainer radiation protection cap. And let them know that you heard about it on the BackTable podcast. And before we get started, Chris and Achal, do you guys do anything special for radiation protection, or do you use the RadPad stuff?
I don't do anything special, to be honest. I have my lead and my lead shields. I've had an interesting experience with the weightless lead system at the VA hospital, which is more of a problem than it is a help. But no, my experience is pretty general, basically.
Oh, so you don't like the weightless setup?
I think it'd be good if I was a single operator. I've had problems with, we have a lot of fellows in our program and people switching positions at the table from first, second, third, and rotating, and that causes an issue.
Gotcha. Okay. Well, yeah, if you're interested, reach out to these RadPad guys. They make a lot of disposable radiation protection materials, as well as, the skull cap is kind of nice to protect your head. What about you, Chris? Didn't you reach out to these guys?
So I did. So in short, I'm pretty similar to Achal in that it's just basic stuff, and that wear the lead and then try and remember to put the lead shield up on a consistent basis. I don't use anything special. I did reach out to the RadPad guys. They sent me some skull caps.
Radiation exposure is a bit of a mystery to me, as silly as it sounds to say. We step in lead boxes on a daily basis and we do our basic things, but the risk of certain tumors or malignancies related to radiation, it's really unclear to me what our risk is when we go in there.
Did you guys get training on that in fellowship or anything?
We certainly did. I think the boxes were ticked, but I don't know, how much of it has stayed with me. And I think the details were a bit vague too. And I think it's because it's unknown,
right,
to a certain degree.
I agree.
So,
the only thing, I guess one of the things I do that I am very consistent about is leaded glasses.
Yeah.
And actually, that's really born out of eye protection necessity, because even when I'm in non-radiation procedures like ultrasound procedures, I consistently wear them. But that would be my only form of eye protection otherwise, and it just happens to be the same pair of leaded glasses that I wear all the time. But I have talked to older radiologists and older interventional radiologists / cardiologists who have developed, radiation-induced cataract. So
yeah, I always wear lead glasses. I think that is one area that's a little clearer. The risk for cataracts as we expose ourselves to radiation.
Well, let's jump into the topic for today. The reason why we have Achal, an interventional cardiologist, as well as myself and Chris as IRs, is we want to talk about collaboration between the two specialties. There's a lot of talk out there about turf wars over different types of procedures, and I wanted to bring these guys on to talk about ways where we can collaborate rather than compete. Just to start off, about our lab setups, are you guys in shared labs, or have you had, if not now, or have you had shared labs in the past?
So when I was in training, it was almost exclusively IR was completely separate from radiology. And so switching over from academics where I did training into private practice, it was kind of adjustment, but all the hospitals that I rotate through in interventional capacity, it's shared labs with interventional radiology and cardiology. And then sometimes, although much less so, occasional vascular surgeon or the general surgeon who does dialysis access. Like there are some surgeons in our practice who create AV grafts or fistulas, and then they will continue to see those patients up for routine maintenance and or declots.
I rotate through 3 hospitals, and they're all academic. 2 of them are major medical centers, and then a VA hospital. Our catheterization lab space is shared with interventional radiology. Vascular surgery does their endovascular procedures there that they don't do in the OR, and neurosurgery actually shares space with us. So I've been in a shared space in this position. Previously I was in private practice, and the IR suite was shared for my endovascular procedures were done in the IR suite. And then there was our cardiac cath suites were separate from everybody else.
Gotcha. Yeah. And so I guess my next question is, what have you guys experienced being any sort of logistical advantages or disadvantages of being in a shared lab? Just quickly share my experience early on. I remember coming out out of fellowship where it was exclusive IR, as you mentioned, Chris, and then going into private practice where pretty much every lab I was in was shared. I remember some of my older, more senior partners warning me that the IR, the ICs, the cardiologists would be, might steal our cases to watch out for them. And I had never heard that before. I'd heard of turf wars, but I'd never really experienced anything like that. And but after several months of working in the shared labs and seeing some other, some cardiologists and in the lab and talking about cases, introducing one another, I actually quickly found out that they were extremely helpful. There were certain ones that were very helpful, and we ended up collaborating on several cases. Some of them were like tricky filter retrievals or DVT thrombolysis cases. There's one cardiologist who had started a PE program, PE lysis program, and wanted to work together on that. And there was another IC that was teaching me how to do radial access. And so I didn't, to me, it came down mostly to personality, but, any advantages or disadvantages to sharing a lab. And I'll start with you, Achal.
Yeah. So I'll start with disadvantages because I personally don't believe there's many, that may be unique to my perspective. But, the main issue would be cath lab time, right? And staff, essentially, and whose case is going when. As a cardiologist, usually I have enough work that I'm not just trying to crank out my cases and take off. I can fill up, waiting periods with other work that needs to be completed. So I think that's the major disadvantage is kind of getting your cases in and having to wait sometimes. To me, there are huge advantages in sharing space with interventional radiology and even vascular surgery. To be honest, I think it's some of the advantages are obvious, right? A flow of information, discussion of cases, running things by each other, and then support. I think there's so many of us doing endovascular work nowadays that none of the minority of us are doing 500 arterial interventions or lower extremity interventions, whatever vascular bed we're talking about. And so it's nice to bounce ideas off people and talk to people about whether it's wires, catheters, devices, and it's been a supportive environment. That's always been my interaction with interventional radiology and the systems I've been in.
Yeah, I actually echo Achal's sentiment in that disadvantages are exactly what he mentioned. It's a scarcity of resources and staff and kind of angling for cath lab time or when cases go. In our cath lab, first start is always kind of a contentious subject. But overall, I've really enjoyed sharing cath lab space with cardiology. I think it's very personality dependent, and it just so happens that the two main hospitals that I rotate through, it's just a good bunch of guys, and everyone's interested in getting their cases done. And if there happens to be time where we can sit around, collaborate, discuss cases, then all the better for the patients.
Yeah, and Achal, you did mention something that I had thought about recently was the staff, right? So if you're in a lab where most procedures are being done by cardiology, those nurses and techs are more kind of cardiology focused, and they seem to be, in my experience, more resistant to doing, or wanting to do IR cases or learning IR cases because the cardiology cases tend to be a little bit more streamlined. And, if you ask them to then go and do some complex GI bleed, they're a little bit thrown out of their loop. So that was one disadvantage I thought of recently. And I don't know if you guys have had issues with that on either side, cardiology or IR.
Yeah, I have experienced that. We definitely, in our mixed labs, we have teams that, are more IR teams or more coronary teams. And, sometimes when you end up with some of the staff from a different team, there's a little bit of, they're not as responsive as you would like. And especially when things get complicated or you start pulling out devices and you need the support of the staff, it can be challenging at times. But I think that's the future of, that's the world we live in now. I think everybody's doing cases right now, like neurosurgery. There's been a big, push for acute stroke care and management in the endovascular suite. And that's seemingly increasing. And I think as hospitals try to be more profitable, and there are many different call teams, we're all going to have to be in the same space. I don't know if that makes sense, but
it's been my experience that, and this was just with my cath lab teams, is that a lot of the techs thought of themselves as cardiology first and IR second.
Right.
It took a long time, and it took a kind of a culture shift, and also it part of it was our practice in that we had to do work, the interventional radiologist, in terms of educating our staff and growing our practice to help these guys get comfortable in interventional radiology procedures. And one of the challenges I think that the cath lab techs and the cath lab nurses faced was, in interventional radiology practice can just be a huge breadth of procedures, and some procedures that just do not come up that often. And so some of the times, if you're talking about doing a lymphangiogram, it just doesn't come up all that often, at least in our practice. And so, people are kind of looking at you like, what the heck are we doing here? But that being said, I think for your bread and butter cases and for the cases that come up not as frequently, but on a semi-regular basis, it just took a lot of education on our part to explaining what we were doing beforehand and how this was translatable. One of the things that jumps to mind is my IR team my cath lab teams always struggled with the difference between when we were doing a declot and when we were doing like routine fistulogram maintenance. And it took a long time before they got the difference and like how these two were going to be wildly different in terms of how much time we needed to allocate and then what they needed to have open on the table and ready. I think that's just one of the struggles that comes across, and having, IR has a huge breadth of procedures, and then you add on endovascular procedures from interventional cardiology, vascular surgery, and neurosurgery. But I agree with Achal in that I think this is the space that we're moving, and the expectation is going to be more and more that, cath lab techs and nurses be expected to be more educated on almost everything that we do.
Yeah, I really think they need to be nowadays, because there's, the demand is high.
Right. And then there's the cost of having separate labs and separate teams, on-call teams. But that has been an issue here in Dallas, is the burnout for techs and nurses, because if they're expected to take, STEMI call with the ICs, and then additional IR call, which could be GI bleeds and tips and all kinds of other crazy stuff, that can be exhausting for these guys.
And now acute stroke call too,
right?
Which is very profitable, and hospitals are trying to. Yeah.
So I don't know if that trickles down to the techs and nurses, but it seems like that's a big griping point from what I've heard and from what I've seen. So a lot of them have gone to the industry, right? And they didn't get a job, working for, a device company.
We definitely have a supply and demand issue in New Orleans. I don't know if you feel this, Chris, but we have a huge proportion of traveling techs and nurses,
right,
at both our major medical centers. You have this, core group that's local and is staying long term, but there's a large percentage of travel employees supporting these labs. And so,
totally agree. Although, in some respects, we've had a traveler nurse that's been with us over a year. He had to take a break at some point because of some regulations. But some of the traveling techs that we have, I mean, they can, like anybody, they can vary in terms of talent and experience level. But some of our travelers have been incredible resources for some of our younger, less experienced local techs.
And the flexibility, ironically, of the traveling techs and nurses is fantastic. Right. They can manage a lot versus an older tech or nurse who's been in one lab their entire career, thinks it's the only way to do it, right? And we all know that's not true. There's many ways to do all the things we do.
That's a great point. You're right. I've been most impressed with the travel nurses and techs for sure. So I did want to touch on what we perceive as turf wars, and kind of what kinds of cases that falls under a turf war. And I was wondering, from the IR perspective, where you see in New Orleans, Chris, and from the IC perspective, what you see out there, even in the academic setting. Let's start with Chris.
For whatever reason, in the main hospital I'm at, which is Tur Infirmary, located in the Metro New Orleans area, we really don't have a lot of turf battles. And I don't know if that just speaks to the practice that the cardiologists and some of the IRs have developed at the hospital, but there's not a lot that we battle over. I mean, there's a lot of cases that we share, but for whatever reason, it's never been a case where I thought anyone was angling for different procedures that I do. There was at one point when I was getting interested in doing more peripheral vascular disease, and there were two cardiologists in particular that I had a pretty good working relationship with, and I talked about getting into the space, and they welcomed it, and they thought it was their opinion that high tides raise all boats, and that if I wanted to get in the space, they thought there was enough work to go around for everybody. The other, and so besides peripheral vascular disease, which I think is something classically people will talk about, quote unquote turf war. One of the things that was a very different practice pattern from when I got to my main hospital was that we weren't or interventional radiology wasn't involved at all in IVC filter placement. Admittingly, this didn't really hurt my feelings one way or the other. And sometimes I've even filled in an inpatient setting or on-call cases that happen to come up. And for whatever reason, an intern or a new intern has consults me instead of cardiology. I've gone in and put in a filter. It doesn't take all that long. It's not all that onerous. And the cardiologists have absolutely no hard feelings about that. I took one of their IVC filter cases away, which is in my hospital, one of the cases that they're more responsible for, or people think more cardiology than interventional radiology.
So, my experience with turf wars, I think for our generation, you can tell by this podcast, it's there's a little bit less war going on and more kind of friendship and support. And I think that's certainly true for interventional radiology and interventional cardiology. That's been my experience. You'll see the older generation guys, and I'm sure this is tied to money and maybe private practice, maybe not, but they seem to get territorial over these things at times. I don't know that it matters so much for me. Vascular surgery, I've probably had more issues with. They're not all bad, but I think there's kind of a systemic feeling within that society that they're worried about their patient population being overtaken by other specialties, especially interventional cardiology. So there's this general consensus that I've experienced that, we're the guys, you're not, right? And that I've come up against at the time. That's not everybody. I think, there's a lot of young vascular surgeons who are supportive, but they're less conversational about peripheral vascular cases than the IR docs are with me.
I agree. I think a lot of it is geographic. There's different cultures in different cities, and and a lot of that starts from practices that have been around for decades, and it kind of just the culture continues. And so, yeah, it's funny you say that, Charles, because in Dallas, it seems like vascular surgery and IR work pretty well together, and for whatever reason, there's the only turf battles seem to be with interventional cardiology for whatever reason. And again, it probably just has to do with local personalities and sort of the culture of these big groups.
I think it's going to become a moot point with time because as patients go out, well, it could go two ways, but if the system kind of supports patients going out and finding their own doctors, and you're bringing in the cases yourself, that's a situation where there is no turf war because it's your patient and you brought them in from an outpatient setting, right? There's nothing to discuss, right? And we see that with outpatient venous disease, right? Whoever brings in the patient can do the work. Of course, I guess the healthcare in the United States could go the other way too, where everything becomes systemic, and then these things are being the pies are being cut up at the top levels, and it'll all be related to money.
I think one of the points you touched on when you said something about local personalities, I think that geography plays a big part in it. I think of New Orleans as, I wouldn't say it's an underserved area, but I mean, not by any stretch. But I think there's less competition here than in some of the places like practicing interventional cardiologists and radiologists in places like the Northeast or California or some more major metropolitan areas. I think when there's less work to go around, then it more becomes a turf battle.
Yeah.
I think that we've done some podcasts in the past when we talked to people who are in extremely underserved areas, and they're like, turf battles don't exist. We're just dying to get someone who can help, right? It's all about finding someone who can help and has the patient's best interest at heart. And so, my advice is, or maybe not advice, but my observation is that, if you just always go in, think of the patient first and try and be friendly and collaborative, you'll find out what kind of environment you're in pretty quickly.
Yeah. And most people with time will respond to you. I think if you're practicing good medicine and taking care of patients, that trumps everything. And with time, even, colleagues that you may be having difficulty with usually warm up and there's a relationship to be had there.
Yeah, and the biggest criticism that I always heard of IRs in the past, and when it came to these little turf battles, was that we didn't have clinic, and therefore we couldn't follow our patients after procedures. And I think that is changing because now all our training programs, it's an IR residency, not a fellowship, and that's going to include much more clinical time with the residency because there are more surgical rotations, and a lot of these programs, these residency programs have IR clinic. So the trainees are going to come out and expect that in their practice. It's going to be harder for them to join a big diagnostic group that doesn't allow for IR clinic time. So I think that, like you said, Achal, that's going to continue to change over time.
Agreed.
Yeah, I think clinic would be great for the specialty. I think that'll be advantageous.
So let's talk a little bit. Chris had made mention of, how and why we do things differently. And we do learn from each other. Like I mentioned, there was when I came out of fellowship, I don't think I'd ever done a transradial case. And I had an interventional cardiologist who was very gracious and was helping me learn how to transradial access. And, for IR, transradial access has become like, a big thing over the last 5 or 6 years, where a lot of outpatient cases, fibroid embolization, even some peripheral arterial disease is being done transradial now. And so I just wanted to kind of talk to you guys about what other differences. I mean, now we're, obviously IR is learning from cardiology in that sense, in terms of safety of transradial access, the convenience, the patients love it. What other things have you seen where IRs and ICs are learning from each other?
Yeah, it's funny you mentioned radial access. We had the chief of IR at Tulane actually was talking to me about radial access cases, and we were talking back and forth about it. And I guess at where we're currently, the IR docs, don't do a lot of radial cases. So we've discussed that a bunch and showed them how we do radial access, and I imagine they'll be incorporating it into their practice based on discussions we've had and our ability to show them. That's kind of, the other thing, sorry, just to digress for a second, the other thing about collaboration, we all get kind of, there's a lot of discussion about physician burnout and us just, spinning the wheel basically and losing sight of what we enjoy. And I think one of the great things about our job and collaboration is the flow of information and kind of discussing approaches to cases and things like that. And, as you were talking about your experience with your, fellow interventional cardiologists, and they're showing you something simple like radial access. I mean, these are the nice things in medicine, and there's a huge advantage in collaboration there and job satisfaction. So.
Yeah, and along the thread of radial access, which we were actually trained in radial access, and it wasn't a major part of the practice, but we used it for select liver interventions and fibroid embolizations. But one of the things that, when we were talking about like some of the advantages to sharing cath lab personnel, that whenever I decided, I was the first IR in my group that decided I was going to start doing radial cases. Had I been in an exclusive IR lab, it would have been retraining techs, nurses to kind of understand room setup, medications that we're going to need to have on hand. But because I was already in a lab that was shared with interventional cardiology, as soon as I said I wanted to do radial access, it was like, no problem. And it was near seamless. And to take that one step further, as far as closing the radial artery, I trust my techs so much. I mean, they're closing more radial arteries than I am. And so as soon as I'm done with the case, I pull the catheter and I walk out the room and, I start doing the note in the control room, and, they're busy, kind of setting up the sheath for removal and setting up the TR band.
Similar to the interventional cardiologist in that same exact lab teaching me transradial, I was able to return the favor by teaching them how to do loop snare technique for a tricky filter retrieval. And, again, for whatever reason in his fellowship, they didn't do a lot of filter retrievals, but in practice, they were doing a lot of placements and retrievals. And so it was just kind of another place where you were able to kind of trade these little tips and techniques, which makes it nice. So,
along the vein of filter retrievals, I was actually, I can't tell you how many times that just by walking through or just by having a shared space with cardiology, how many cases that have been referred to me. One example I was thinking of, I was watching a cardiologist. I was going in to do a case. I don't remember what case it was. And I saw this filter. He was about to retrieve it. And the filter tip was completely embedded in the IVC. And I saw the venogram before I went in. And then as I was coming out, I saw him trying to use the loop to snare the tip of the filter. And I mean, he was going through all the right steps. But at the end of it, I found him when he came out and he wasn't able to retrieve the filter. And I said, I think this would be a good one to, do a loop snare technique or do a modified Hangman's where you, retrieve the filter tip, or you snare the tip of the filter and then pop it off the sidewall and then, do traditional techniques to remove it. We didn't actually do the case together, but he was just kind of thinking to himself. He's a little bit of an older cardiologist. He's like, as I was explaining the process to him, he was like, how about this? He's like, I'm just going to let this guy, go home today. And he's like, we'll bring him back in a month. And he's like, I'll just send him to you. And I was like, oh, that's fantastic. I think, it's a win-win. I was just happened to walk by while he was doing this difficult filter retrieval and kind of acquired a case because we happened to be in the control room at the same time.
The other thing I wanted to touch on was I've noticed, or just, on the word on the street, hearing about these outpatient labs, OBLs, and a lot of them being staffed by a combination of vascular surgeons, interventional radiologists, and interventional cardiologists. So you see them working all together a lot of times as part of the same practice or as independent contractors in these OBLs, which is a neat concept. And I hope the trend continues because it's led to a lot of collaboration in the outpatient setting. There's a whole society called Outpatient Endovascular Interventional Society, Outpatient Endovascular and Interventional Society, OEIS, and they have a conference every year. And I had the opportunity to go to this last year's conference, and it's pretty amazing. The information that's presented at this conference and how useful it is, and just neat seeing all three specialties get up on stage and tell similar stories and stories about collaborating. So I urge you guys, if you have any interest, it was a definitely worthwhile conference, and I think it's a worthwhile society to contribute to help continue the collaboration.
Actually had one background question for Achal in that, what does an interventional cardiology training look like in terms of like once you get out? I mean, I know most people are doing not intern years. You do 3 years of residency as internal medicine, then you go into cardiology. But I always got a little fuzzy about what happened after the cardiology fellowship, and then whether people went on to do additional fellowships and more interventional. And so I just wanted to hear a little bit more about the training.
Yeah. So cardiology training has kind of changed over there. As it used to be, 3 years of internal medicine, or probably less, in the 80s and 90s, and then 2 or 3 years of cardiology fellowship. And then, a lot of these things were new. So if you want to become an EP doctor, you'd kind of fashion yourself as an EP doctor and learn on the go. Same thing with interventional cardiology. I think in the late 90s, they started having dedicated fellowships. And since then, I don't know why necessarily, but we're creating more and more fellowships. So a standard training would be 3 years of internal medicine, 3 years of general cardiology or non-invasive cardiology, and then the opportunity to do multiple different subspecialties. And some people do multiple. So I, for example, did an interventional cardiology fellowship, which was 1 year, and then I did an extra fellowship in peripheral vascular intervention. So I did 8 years. There's heart failure training, there's imaging training, there's MRI training versus CTA training. Echo training, it gets pretty, there's structural training now as well. So there's actually, believe it or not, there's 3 separate interventional fellowships you could do after your general cardiology fellowship.
That's pretty impressive.
It's certainly a broad scope or spectrum of disease that cardiology is trying to manage.
All right, Chris, on that same note, for our cardiology listeners, can you explain the training for IR? Because they may not be familiar with how we get trained.
That's a good point. I may not be even the best person to do this anymore because, as you know, it's been in flux. But so traditionally, the way I was trained, and I'm almost positive the way you were trained, Fritz, was 1 intern year. So 1 year intern year could be in internal medicine, surgery, or whatever. And then you did 4 years of diagnostic radiology, followed by 1 year or possibly 2 years of interventional radiology. And so interventional radiology was a 1 year or possibly 2 year fellowship. And now everyone moving forward is going to be interventional radiology residents that go on to, actually don't even go on. It's just interventional radiology residency. And there's not really an interventional radiology fellowship anymore. It's been phased out and been replaced with the residency.
How long is that interventional radiology residency?
6 years, right?
Still 6 years.
So it'll be like 3 general radiology and then 3 interventional, or sort of.
What they've done is they've kind of woven into the fabric of the training that your intern year is a surgical based year, ICU months, clinic, vascular surgery months are built into these rotations, and then diagnostic radiology is built in, all peppered throughout. And then as you're kind of marching through each year, you're doing increasing numbers or increasing months of dedicated interventional radiology. So you get less diagnostic radiology, more clinical based cross training between vascular surgery. What else? Vascular surgery, ICU training, and then a lot of interventional radiology peppered in there.
All right. You know, one interesting problem we're having from a procedural basis is we're having trouble with volume. There's been big changes in volumes for our trainees. Have you guys been experiencing that?
I would say, and I'm not going to pretend to be one of the guys with my fingers on the pulse of how training is going, but it's been my experience that interventional radiology volume is on the up in general, in terms of we're getting into spaces that we previously haven't been in, on top of we're advancing different areas that we have already existed in. I think of like some of the body work that we've been doing. Like, I think everyone has placed cholecystostomy tubes or tubes that go directly into the gallbladder to treat acute cholecystitis in non-surgical patients. And now, when I think about like one of the extreme IR podcasts that we did with Jeff Chick, now people are segueing that into using that track into the gallbladder to do, stone removal cases. And that's just one example of that. It was previously a very basic procedure, and now it's getting more advanced in terms of like the biliary work that we are doing. What do you think about the volume of interventional radiology, Fritz?
Yeah, I agree with you. I mean, just 6 or 7 years ago, people were saying, "Oh, IR doesn't do peripheral vascular disease anymore," and then now there's this resurgence where people are taking that. I don't know if you want to say taking it back, but the younger IRs are coming out, better trained for it and more hungry for it. So I think in terms of peripheral vascular, and we see more of it. For example, SIR is bringing the Learn conference back, which is focused on, peripheral vascular disease. And that had disappeared for, I think, 5 or 6 years. And so I think that IRs are being more clinically focused. There's a lot more IRs the young IRs are coming out wanting to have a clinic, wanting to, be more clinically focused and not sitting in the reading room and reading diagnostic all day long. So I for whatever reason, I don't know what's behind it. Maybe it's efforts from our society. But yes, I do think that we are doing more than we were even 5 or 6 years ago.
Yeah. When I talk to some of the trainees who are so I trained at Georgetown for fellowship. And when I talk to the guys who are training now, and not to say that my training was subpar or lacking in any way, I thought it was a very well-rounded program. And the cases that they're doing now, they're doing more cases, more difficult cases. And so, from my perspective, a very limited sample size, just my training program already looks much better in terms of volume and level of difficulty and technical skill than what it was 3 years ago. I'm only at 4 years ago. I was there 4 years ago.
Yeah. So, I think in interventional cardiology, we've seen the complexity increase at the major medical centers or in the urban areas. But what's happened is the overall volume for each individual institution has gone down significantly. And I think it's because we have too many labs or too many hospitals. But, I'm being selfish in my evaluation of that, right?
Well, I agree with you. I mean, you're right. In Dallas, we have just there's a hospital, it seems like, on every street corner. And there's incredible competition for these facilities to bring in patients. And but there's also all these outpatient labs opening up as well. And so that might be responsible for some of that decrease in volume at the hospitals.
Yeah. And we're overtraining too. I don't know if you guys are running into that problem.
I think historically we have undertrained.
Yeah. Cardiologists like to shoot themselves in the foot, it seems like. At least they have been for the last 20 years.
Do you guys ever use CO2 angiography?
We do. We have it available to us at Tulane Medical Center, and we use it occasionally. One of my colleagues, who's a very skilled peripheral interventionalist, uses it routinely on his renal failure patients. I tend to, acute renal failure related to contrast-induced nephropathy seems to be less of an issue than it used to be, and it's certainly, I think, lower risk now than it was before. So, there may be a time that I'll use it every now and then, but I don't use it routinely.
I just knew that you guys were over at Tulane, and I know that they have a really robust CO2. I mean, I think I think the techs are very well trained on it.
Yes,
it's no problem. Yeah,
absolutely. This is the first institution that I've used it with again guidance from my colleagues and even some of the techs who are familiar with it. And I've used it. It's come in handy. And I think I mean, listen, depending on the workup going in, sometimes based on the non-invasive imaging, where the issue is,
sure.
Right? And you need a half a picture to clear your, to move on to the next step. And it can be helpful in that situation, or as a diagnostic and staged intervention, it can be helpful. But yeah, we have it and we use it sometimes. The images are certainly not as good as DSA.
Absolutely.
As you do
expect. The other thing I was going to mention in terms of just having to hang around the cath lab suite, lingering, like I put in all my notes and all my order sets as I'm leaving the case. I've gotten 2 really fun cases very recently in terms of bifurcating lemas that the cardiologist happened to bring me over, and he's like, hey, take a look at this. Right. Yep. So Achal just asked me, he's like, oh, coil it. And yeah, so the cardiologist asked me to get involved to do a coiling case. And it's a very straightforward, very, very simple procedure, but not one that I had ever done in fellowship. Wow. I mean, certainly we have skills that are translatable to a lot of different things, like putting a coil. It's just in a different blood vessel. But those were 2 kind of fun cases that I've enjoyed and that I just happened to get by walking through the cath lab at the right time. And actually, I probably got the first one just by walking through at the right time. The second one, they kind of found me out when I was happened to be kind of nearby.
So explain like why you coil it, and just can you just quickly run us through that case?
Actually, let me tell you what I know about that case, and I'll then let Achal actually explain it, because I actually presented this at one of my angio clubs, and one of the things that I really liked about this case, I mean, there's always this move to become very clinical and longitudinal care and seeing these people pre-op and post-op. I did absolutely none of that. I mean, literally the cardiologist was like, this is the lima, which I could recognize. And you see the branch that's going to the heart, and then you see the branch that's going to the thoracic sidewall. And I just literally radial access, dunked a rim catheter into the lima, did a DSA, and then put a microcatheter and a couple coils in like the bifurcating branch, the branch that was not going to the heart. And that's the extent of what I knew about it. I met the patient once pre-op and then never saw him again. But I've had assurance from the cardiologist afterwards that it worked and it was successful. But that was my total knowledge of the case going into it.
So it's stealing blood flow away.
Exactly. Exactly. So that situation's a steal syndrome, and maybe the patient had significant coronary ischemia in their anterior wall. That's usually where the surgeon attaches the lima graft to the left anterior descending, which provides blood flow to the anterior wall of the heart. So maybe the patient had symptoms or an abnormal stress test that showed ischemia in the anterior wall, and the interventional cardiologist wanted that lateral IMA branch closed off. Usually the surgeons will tie off those branches, but every now and then we'll shoot a lima, and they are some residual branches that may or may not be causing steal.
Yeah, that is.
Would you have felt comfortable coiling?
As you're saying it, so the major thing you have to worry about when you're in those procedures would be causing damage to the lima, because you'll lose flow to the anterior wall. So maybe if it's a proximal, I'm assuming it was a proximal branch, or
pretty proximal.
Yeah, so that's a safer situation, and really those limas can be delicate, especially when you're engaging your guide catheters. At the ostium, and you have to be really mindful and careful not to dissect. Essentially, that's the main thing. That's what you have to worry about. And then, of course, anything else, any other situation where you may compromise flow to the LAD, you have to worry about.
Well, thanks again to our guests for coming on, Chris and Achal. I just want to thank our sponsor, RadPad, again for sponsoring this episode. And thanks again, guys. Have a good Sunday.
All right, thanks, Aaron. Thank you.